welcome back to Epi Seminar, everyone. This is a really exciting Epi Seminar. It's always great to have like old friends come back and give seminars. So I'd like to introduce you to Dr. John Snyder, who is the Director of Transplant Epidemiology for the Chronic Disease Research Group at HHRI, or Hamilton Healthcare Research Institute here down the street, actually not too far away. He's the director of the Scientific Registry of Transplant Recipients. And he's also like a whole bunch of other things, but like I want to tell you a story first. So I don't want John might know the story. So John and I were PhD students at the same time. You know the story I want to know. And like the first semester I was in the, what year did you graduate?
2007.
2007. Okay, so the first year I was in the PhD program, John and I were both taking Aaron Folsom's CVD Epi class, which at the time met at 8 a.m. on Monday morning. And the hardest thing I ever had to do with my doctoral program. And there was a group project, and the group project was like something like design a study about CVD. And John and I were in the same group. And I was like this person who, I was like the first semester of the PhD program. I didn't know what I was doing. I don't even like it's weird that I was even here. John was like one of those PhD students that like, you were like, oh wow, like he like really knows what he's doing. And so John was like, why don't we do a study about like kidney transplants? Because I already sort of know. And I was like, great, that's our group project. Great. So we did that. And then John was like, and this was like a design study. And John was like, you know, I kind of have the data. Like we could just do this study. We could just like analyze this data and like have it be the project. And I was like, okay, fine, like, sounds good. And so like that was our project. Like we like designed a study and then did it. And then afterwards, like for the rest of the semester, Aaron was like, oh, you guys should really publish that. And John was like, yeah, I don't know, I'm kind of busy. I don't really like, I have all this other stuff I need to do. And he was like, if you guys want to publish it, you can, I don't know. And like everyone else in the group like didn't know what they were doing, so of course we did. But like it was just like a super like the whole it was like super fun. And at that time you were already a statistical editor, I think, at yeah. So definitely like you know, in your PhD program, John was always one of those students that I was like, whoa.
You're too kind.
So it's great to have you back. As you might have gathered, he got his PhD here at Epi, and you also had a master's from here in Boston. Yeah. Okay. Well, thank you so much for coming back. It's great to see you, and I'm really excited to hear. Maybe you're presenting on like the CVD Epi project.
I can change my slides. Thank you, Rachel. Just thanks for the invitation, and that was too kind. I have very fond memories of that class, the CVD Epi class, and my favorite memory. Dr. Folsom was my advisor, and I remember the very first morning of class, he started class by pacing a little bit up front. Before he said anything, he just was kind of like this. And then he turned into the class and he said, I've been teaching CVD Epi for a long time. And this is the first time that I've thought to myself, why am I teaching this class? He said, don't smoke, eat well, get some exercise, reduce stress, you know, what else is there? And then he kind of walked away. And all the students in the class were like, guess we don't have anything to learn in this class. Yeah, he knew the big ticket items, but yeah, it's great to be back, see some old friends. Dr. Jacobs was on my committee, and so it's just great to be here. My whole career pretty much has been in kidney disease first, and then branching out into solid organ transplantation more generally. What I'm hoping to do today is just give you a sense of some of the exciting things that we do as epidemiologists in this field. I have one example that I'm going to spend most of my time on today that I think is pretty interesting. Hopefully you'll think it's interesting as well. But just to give you a sense of an epidemiologist's role in this field. But we'll keep this casual. Stop me at any time, raise your hands, ask questions. Happy to do that. So Rachel gave you some of my background. So I have worked I just had my 25th year anniversary over at Hennepin Healthcare Research Institute, which is the research institute just down the road inside HCMC. It's an affiliate research institute of the University of Minnesota Medical School. So we have ties back and forth across the two. Within that, I lead the transplantation group of CDRG. CDRG stands for the Chronic Disease Research Group. And I'll tell you a bit more about that. So that's my role. Rachel mentioned this, Director of Transplant Epidemiology. My background, I did my undergrad at St. Olaf College in mathematics education. Thought maybe I wanted to be I was certified as a middle school math teacher. Never did that. I thought of better ideas to go forward. So came to Minnesota and did the biostat and the PhD Epi, and I hold appointments here in Epi as well as in the medical school. So, just real quick, a brief bit about CDRG. Again, that's the Chronic Disease Research Group. We're about 50 employees over here down the street, and these are the areas that we are doing research in right now. So nephrology, oncology, transplants, the team that I lead, bone and mineral, cardiology, hepatology, and inflammation, and always trying to branch out and add more boxes to this slide as well. But again, we're about 50 people on site there, and then we also have about 25 clinicians, surgeons that I employ around the country that help us in the field of transplantation. So in my team, we're about 50 altogether, 25 here in Minneapolis and 25 all dispersed around the country, lending their expertise to us. Rachel mentioned the SRTR. This is a federal contract that we operate. We're in our 15th year operating this contract. That stands for the Scientific Registry of Transplant Recipients. It's essentially the national registry of all solid organ donation and transplantation in the US. I'll talk a lot about what our role is in that. It's a lot of reporting, outcomes monitoring, but the most exciting part, and what I'll spend most of my time on today, is that we provide research consulting, if you will, to the policymaking committees that are trying to wrestle with policy in transplantation. So that's the most exciting piece of that project. That's probably about 90% of what I spend my time doing, is leading that effort. So that's an exciting project. Our group also runs the United States Renal Data System. I know that there are some faculty in the room that have worked with that data set. That is the registry for all end-stage kidney disease patients in the country. So anybody who's on dialysis or has had a kidney transplant. So this registry, what's different about the SRTR is this is not just kidney transplant, it's all solid organ transplant. So what do I mean by solid organ transplant? Just to set the stage of the things that we work in. Our team does research in all of these components. So we talk about solid organ, we're talking about heart transplants and lung transplants, as well as, so those are what we call above the diaphragm transplants, okay? And it's interesting because the field is actually split that way. It's like people talk about, I'm an above the diaphragm person or I'm below the diaphragm. So when we get below the diaphragm, we're talking about liver, pancreas, and kidney. Also, that you can do small bowel transplants. So this is mostly done in young children. Omaha is a primary center for this type of thing. And there's one other, does anybody know what this is? They're called VCA transplants. Anybody heard of this? It stands for vascularized composite allograft. Allograft means you graft something from another human being onto another human being, right? Anybody have ideas what that would be? Skin, yep. I'll give you the rundown of what that all includes. There's a number of different things that are being done now. These are still pretty rare, but you're seeing more and more of these, and these are defined in federal law as solid organ transplants, which is a bit odd because they're not organs, but that's why they're called vascularized composite allografts. So it's just, you take a bunch of tissue and you take it from one human and you put it on another, essentially. So we're talking about scalp and face transplants, abdominal wall and upper limb transplants. So you can do hand transplants. You've probably seen face transplants in the news. Gosh, about 8 years ago now, the National Geographic did their cover story was face transplantation. So they had this huge spread of face transplants. Mayo Clinic has done a few of these down in Rochester. And then there's some reproductive organ transplants, both uterus and penis transplants are being done. The interesting thing about uterine transplants is that this is the only transplant that is meant to be temporary. So you can transplant a uterus from either a deceased donor or somebody who's alive and wants to donate. You sometimes see mothers wanting to donate to their daughter who might have trouble getting carrying a pregnancy. And so you can do the transplant, and then there's attempts made to bear a child. And then after that is successful or not, they will remove the uterus again, because otherwise the patient has to continue to take immunosuppressive medications for the rest of their life, and those have side effects. So that is the only one meant to be temporary. So it's an interesting field. So I won't talk a lot about VCA, but just to give you a sense of the types of research that we are involved in. So a few years back, we hosted a consensus conference to pull a number of stakeholders together to talk about our system. And this is one of the things we're charged with as the SRTR, is monitoring the system. Okay, so what we were doing at this consensus conference, we held it down at the Radisson Blue at the Mall of America. We had about 200 people in attendance. We had about 50 patients that were there, which was fantastic. We were really trying to engage the patient population to talk about the kinds of data, the kinds of research that people would really find valuable. So it was a really great experience, but we have on our team somebody, I didn't know this was a degree, but this person is a human-centered design engineer. Anybody work with these types of people? These are good people to know. Okay, so we were talking about designing this conference, and he came to me with this map. And he had drawn this up and said, well, you know, it's helpful to orient us to how the system works, right? And so what was useful about this is we were able to, when we were talking with patients or professionals about the types of data they would find helpful, you can talk about the stops on this subway system. We designed this intentionally so that the patient experiences the middle line, right down the middle of the blue line. So the patients go from left to right across this, and then all of the other lines are meant to be other components of the transplant system that come alongside the patient at certain points in their journey. And so we used this to really orient people to say, okay, let's talk about stop E. You know, when patients are actually put on the wait list for an organ transplant, what types of data would the patients find helpful at that time? Or even upstream of that, what types of data are useful? So we systematically went through this and talked about the types of research, the types of information that both the professionals would find helpful, the surgeons, the physicians, the nurses, the coordinators of these programs, as well as the patients themselves. And so the bottom line, the yellow, is the living donors that come alongside patients at times. There are two possibilities currently for, well, I'm not counting the uterine, but for a living donation, kidney and livers can be donated from people that are still alive, right? For liver transplant, they take a lobe of your liver and they'll transplant it. And the liver is the interesting one because it actually regenerates. So within a few months of you losing a lobe of your liver, it will regrow, which is amazing. Why don't other organs do that, right? So yeah, we just found this helpful. I just show it to you just to think about the complexity of the system. You see some in there, there's some regulators and insurance providers that come alongside. The whole brown and orange at the top are the deceased organ donation side. I'll talk some about that today. You know, that's the organ procurement organizations. Has anybody heard that term? They're OPOs. Life Source is right up the river here. I'll talk some about them. They're the ones in charge of working with the hospitals when they have somebody who could be an organ donor to make sure that we manage that process and get the organs offered out. So that gives a sense of the system that we monitor. We have data for most of this. There are components that we currently don't have, but we're working to get them. But we have data in our reporting that really covers this span. Yeah, question.
It's not a quick question. I know of like the United Network for Organ Sharing and the OPCAD.
Correct.
Like, how does that map on the SR?
That's a great question. Yeah, I didn't show the diagram, but so the Organ Procurement and Transplantation Network is the federal system that actually runs the actual nuts and bolts of this. So as this whole process is playing out, they manage the compute environment that has the wait lists. They have the environment that the hospitals are logging into to do the matches and generate the, you know, and make the offers. So that is a federal contract that's operated by UNOS. Sometimes you hear that phrase, or they make their way onto some of the medical dramas on TV sometimes, right? United Network for Organ Sharing, or UNOS in Richmond, Virginia. They have been the federal contractor that runs that. They're in Richmond. Our contract as the SRTR is the scientific arm of that operation. So they collect all the data. They ship the data to us monthly. We have a feed from them, and so we update our database monthly. So we are like a sister to that. So we're not running the day-to-day. Our job is to do the reporting and the research on the data. So great question. Okay, just set the stage a little bit about what's currently going on in transplantation. There are 104,610 people on the wait list as of about a month ago, exactly a month ago, I guess. Just to give you a sense, most of those are waiting for kidney transplants, 90,000 of them. And you can see that liver, heart, pancreas, lung, intestine. I'm not showing you all the possibilities here, but these are, you can see that kidney far outweighs the others. Kidney is the biggest wait list. And I always like to compare that then to how many transplants are being done in those organs. So the yellow bars here are last year, how many transplants were done in that type of transplant. So you can see kidney, the wait list far outstrips the 28,144 transplants that were performed. And you can see for some of the other organs, it's fairly close. And so the trick is though, is does the right donor pop up at the right time for the right patient, right? Just because we've got more transplants being done than people on the list doesn't mean that people don't die while they're waiting if we don't get the right organ at the right time. And so the red bars here, sometimes hard to see, but I put the numbers. Those are the patients who died waiting last year. So in kidney, 8,486 patients died while waiting. And you can see the other organs, numbers across the other organs there. So that's the challenge, right? How can we minimize that situation? I think of that as a failure, if you will, to save these lives, right? So how do we best do that? One of our jobs at the registry is to help to do this in smart ways. So I'm going to try to give you some examples of what I mean by that. So I consider that the missed opportunity. We've got about 13 people dying every day while they're waiting. And these are people that actually die. If you add on these additional 16 people per day that are removed from the wait list because their medical team now thinks they're too sick to survive the transplant, that's an additional 16. So all that adds up to currently about 29 people that I think the system fails every day. Okay, so that's the challenge that we're trying to work to minimize. And just to have a little fun about it, I was thinking, you know, down the road here, we've got the stadium, right? And that stadium seats 50,805 according to their official website. So I didn't put the source, but if you want me to source my data. So if they sell out 2 full games, that would be 101,610, and the current wait list is 104,610 people. So you can visualize the stadium completely sold out twice. That's the number of people waiting for a transplant. So I'll come back to the stadium here in a minute, but when we look at how many people are being newly added, so you can think of this in epi terms like incident waitlisting patients. Okay, so these are newly added waitlist patients each day. And what's being shown here is a 1-year look back rolling average. So kidney is the top one, right? We've got the most kidney registrations every day. So these are newly added people to the kidney transplant wait list. So the rightmost point on this is the most recent data we have. We update this monthly, and that's just under 50,000 people. So what that means is in the last 365 days from that point, there were 50,000 people added to the wait list. We have an application on our website that tracks a number of things like this so that we can look at trends over time. I'm going to go through a few of these just in some quick detail for you, not to put you to sleep with a couple graphs, but you can see, you know, interestingly, I'll zoom in on kidney. So this is waitlist registrations, and we highlight in some of these plots when there were key events that happened. Obviously, the COVID-19 pandemic was a critical moment in this field. A lot of kidney transplants are, because there are so many living donor transplants done, they didn't want these happening in the early phase of the pandemic. Living donor transplantation almost shut down completely right when the pandemic hit because these were considered elective procedures at many hospitals. And so unless it was a dire situation, they didn't want people coming into the hospital to expose themselves. So you can see what happened here. People just stopped being added to the list, and then it kind of picked back up over time and sort of back on track now. These are registrations, but when you look at the point prevalence size of the wait list, this is what's happening in kidney. And it amazes me. You often hear, you know, news reports. Actually, transplantation has been in the federal news or the U.S. news quite a bit of late, and you hear things. You hear people say the wait lists are huge and they're growing. Okay, they're actually not growing. This is the point prevalent daily estimate of people on the list. So we've been tracking this. You can see it's actually been pretty much in decline for over a decade. It's plateaued over the past year or so. So that's something we're watching. I think we know some reasons of why that would be. But in general, you think of sort of inflow and outflow of the wait list, right? So you've got increasing registrations, but you've got overall decreasing size of the list. And so that's because our transplant rate keeps increasing. We're doing a better job of getting organs to the right people and getting them off the list. This has been improving. The CAS 250 line is a policy change indicator. I won't get into that for now, but sometimes in these plots, we can mark off when those policy changes happen, because it's interesting to see what policy does to these trends, right? That's why we're doing this. So that's kidney, but similar stories. Before I get on to the other organs, this is another thing that we're tracking, and it's a bit of a crude idea, I guess, but this is tracking for each transplant that's done, how many people are dying. Okay, so if we just take the ratio of those two things, how many transplants were done over the past 365 days versus how many people died waiting. And so a 3 here, you can see it's about 3.25 on the right. That means for every 3.25 transplants done, 1 patient dies. So this has been getting better. Going up is better, right? We want more transplants relative to people dying. So that's a good thing, I think. Go ahead, Ray.
I know you said you didn't want to get into it, but can you just vaguely say what that policy?
Yeah, the CAS 250
Yeah.
line. Yeah, well, I'm going to get into this in
Okay.
great detail, actually. Not specifically the CAS 250, but I'll come back to it.
Okay.
Sound good?
Yeah.
All right. This is what's going on in liver. So again, you see that COVID affected the registrations and then they rebounded. The rebounds also, by the way, were pretty, they coincided with the vaccine releases, right? So that's when people kind of got back to normal. And this is what's happening to the point prevalent waitlist size for liver. So it's a very similar story, right? The transplant rates are going up. The transplants per death are going up. Good things happening there. This is what's happening in heart. Same thing, waitlist size is going down. That one also has leveled off a bit of late. So we're kind of tracking why that might be.
Sorry,
Yeah, go ahead.
are heart donors car crash victims largely?
No, I mean, there's 2 different paths to donation. One is brain death, right? And the other is circulatory death. We call these DBD or DCD donors. Car crash victims, yes, but can be overdose victims, can be accidents, can be trauma, shootings. They're not all.
But the majority is not car crash victims,
For heart specifically?
or for the non-living donor.
No. Stroke is the current leading cause. Okay. Yeah, another question.
So if someone donates a heart, do they also donate lungs, other
Good
organs?
question.
Like why the discrepancy between heart donations and lung donations? Kidney kind of makes sense, right? Because you can donate a kidney. But for the other ones, is it typical when someone donates a heart, the rest of the things get donated too? Or are people like selected?
It's a good question, and part of it is the nuance in how I'm presenting the data right now. So there's a difference between how many donors we have and how many transplants occur, right? So you have a donor, the organ procurement organization is going to go after every one of those organs. They might medically rule out some of them. Okay, there might be reasons that they can take the abdominal organs, but not the thoracic organs, or vice versa. So it depends, and then they can offer them out, and no transplant center might want them. You know, maybe the kidneys and liver were great, but the person was a 30-year smoker, and the lungs are bad, and so they, you know, so it's some of those issues. There's other considerations as well. Lungs are the one organ that is very size dependent. You have to fit the lungs to the cavity of the recipient, right? So you can't take adult lungs and put them in a child or vice versa, right? So you need to, that size matching component is real. So if they can't find somebody in time to take those lungs, there might be a reason they're not used. So the answer is the OPOs will go after all of those organs, and they might not get them all placed.
One more quick thing.
Yeah, David.
You mentioned overdose. Is the opioid overdose epidemic actually benefiting transplants? How?
Yeah, That's a great question. The CDC, did you see the report the CDC put out last month on this? They are tracking the opioid epidemic, of course, and there was a large NPR article just last month about this, that it's coming back down now. So we've seen it, I think, peak, and it's been coming down the last few months, which is great. And we see that directly reflected in our data. I presented on that at another conference about 2 weeks ago. I overlaid the opioid deaths that we have in the donor population versus that CDC report, and the lines look exactly the same. So I hate to use the term benefiting the transplant system, but I think your point is exactly right. I mean, there has been growth, but there's been growth in other causes as well. There is some press out there claiming that all growth in transplantation is on the backs or the heels of the opioid epidemic. I don't believe that to be true. We've been getting more donors across all types of death. So it's interesting to track it though. And the brain dead population, which most of the opioid deaths go down the brain dead pathway, that tracks almost exactly with the CDC data. It's pretty interesting. So this is hard. Again, this is the transplant rate has been increasing. It's recently plateaued, so we'll be watching that. They are working on a new policy currently, and this is transplants per waitlist death. So just to set the stage, the last part is lung. Lung was the biggest effect of COVID, right, for obvious reasons, right? So lung transplantation really took a hit in the COVID phase, and you can see that the point prevalent size of the waitlist plummeted at the start of the COVID pandemic and has still continued to be lower. I think what happened there is transplant programs took the opportunity to look at their lung population, and if they removed them during the pandemic from the wait list, they just felt they weren't candidates to be removed back. So we didn't see this kind of recovery happen in lung. So interesting there. All right, let's jump ahead to one of our roles, as I mentioned, is we provide epidemiologic support to the policymaking committees. So there are committees that are run by UNOS that make policy about how we operate this system, right? And when they need information to make good decisions, we provide that. So I'm going to give you some examples. So I'm back to the stadium. So think of all those people in the stadium waiting for an organ. How do we decide who gets it? We're not randomly throwing them into the crowd, okay? This is not a random process. There is order to this, and this is what the policy is for. It's not an auction. Some people have suggested this as a way to do this, is just let people bid on organs, okay? I'm not a big fan of that concept, so we don't do that either. Waiting in line is closest to the truth, but this is nuanced, right? Some people think I'm on the wait list. You might hear this. I've been on the wait list for 5 years. I'm moving up. Okay. They think there's one line. I think most people do. But there really isn't. It's a bit more nuanced than that, and I'll hope to show you some bit about that. But first, one of the things that we have been working a lot on is the problem of geography and allocation. And I think, in my view, this is one of the more interesting aspects of what we do. The US is a big country, so we deal with geography in a way that a lot of other nations that have transplant programs don't deal with. Okay, so how do we think about geography? And so I just want to give you a bit of history here. So in the early days of transplantation, and transplant's really not that old of a field, right? I'm talking like in the 80s here, like the 70s and 80s when this was first getting really going. What would happen is a donor hospital would have somebody say HCMC has a death and the patient's brain dead, and they know because they talk to the University of Minnesota, who had an early kidney transplant program, that they've got somebody waiting that they might want to put a kidney in. And the physicians over at HCMC would call the university and say, hey, I've got somebody. And they would do try to make it work. Essentially, it was literally a phone call. They called who they knew, essentially. So there were these relationships. And then these organ procurement organizations began to be created by the federal government to manage this process. And they began to match donors to patients in need. And this was in the Reagan administration in the 80s when they decided that we need a federal system here because there's patients waiting all over. And if we're going to be equitable and fair to these patients, we need a system and policy to govern how this works. So that is the early field. So There are currently 55 of these organ procurement organizations, and they have federally designated service areas. And this is the map of those service areas as it exists today. And so you can see, I'll zoom in on the Minnesota one since that's where we are. This is the area. So this is managed by LifeSource, which is just up the river here. And what this means is any hospital with an ICU, if they have a patient that has been declared dead, and they by law have to call LifeSource. They have to notify LifeSource for in-hospital deaths. Okay, now only about 2% of those types of patients actually go on to be viable donors, but every one of them gets referred to the organ procurement organization. The other blue dots on this map are where the transplant programs are. So those aren't all the donor hospitals, right? There's many donor hospitals. All you need is a ICU. Any hospital with an ICU can actually have a donor. But the other dots, so we've got Mayo here, and on our website, if you hover around on these dots, it pops up what types of transplants they do. And there's 4 hospitals in the Twin Cities here that do transplants, so that's why there's a 4 there. If you zoom in on it, they pop up. So anyway, so this is the service area, if you will, that Minnesota serves. And the reason that's important is because the evolution of how geography was handled in these policies is important. So I'm just give you back to the history lesson here. So in 1984, there was a federal law passed called the National Organ Transplant Act, or NOTA for short. And then there was a subsequent final rule that laid out the policy and how people are supposed to abide by this. The final rule wasn't actually finalized until 1999. So things take a while in the federal government. The law was passed in 1984. The final rule about how everything's going to operate didn't come out until 1999. So you can see how relatively recent this all is. So in 1984, I'm just going to highlight a few key things as it relates to geography. And it created the OPTN, which we had a beautiful question about the OPTN earlier. So that's the group that actually organizes all this. And I bolded the key statement here. The OPTN will assist organ procurement organizations in the distribution of organs which cannot be placed within their service area of the organization. Okay, that was the original language in the law. Okay, and so you think back, I'm going to back up. This is the service area. So the way the law was originally written was if LifeSource procured an organ in this area, they would try to place it in that area. Okay. And if they can't, then they could use the national resource at UNOS to try to place it somewhere else. Okay, so think about a donor that pops up at Mayo in their ICU. They're going to offer it to all the blue dots in the blue shaded area first. So they might actually offer it to Bismarck, North Dakota, before they would call Madison, right? And this is closer. And same thing with Des Moines, maybe, and over Iowa City. But that's the way the system was set up, and it operated like this until very recently, which we always contended was a bit not the best way to do this. So it's interesting though. So back to this law. So again, the first idea was if they can't place it locally, then we'll get involved. We'll help place it nationally. In 1988, they amended this. And they changed the language to this: assist organ procurement organizations in the distribution of organs, period. It didn't say anything about their local service area first, but there still at this time wasn't national policy to dictate how this is done. So it was still a problem. They changed it again in 1990. So you can see the evolution of this. They said in 1990, well, we're going to assist organ procurement organizations in the nationwide distribution of organs equitably among transplant patients. So they're starting to realize that this is a national resource. There's no reason we should restrict this to these blue areas. Let's figure out a better way to do this. And so then in March of 1998, this is now 8 years later. This is still a very slow process. They released this press release to call on creation of organ allocation policies that are based on medical criteria, not geography. Okay, so they're still trying to 8 years later, they're still trying to figure out how to deal with geography in these policies. And in 98, they issued this final rule, which was set to go into effect in July. And the final rule set out standards for how we're going to distribute these things nationally. And again, their press release at that time, this is a screenshot of it. They ruled, the rule calls for organ allocation based on medical criteria, not geography. So this has continued to be a struggle now. We're 15 years past when the law was made, right? So the new rule was actually put on hold. This is just some language out of that. Maybe I'll skip over that for time, but they suspended implementation because people sued the government thinking this was overreach and they can't dictate this kind of policy, and so lots of things were happening. So in 1999, they had referred this to the Institute of Medicine. They wanted the Institute of Medicine to weigh in on the ethics of national policy. Okay, so they're still trying to get rid of these blue zones, if you will. And then in 1999, they published the final version, and this is essentially still in effect today. And it's basically the key here is that the policies for equitable allocation of cadaveric, we don't use that term in the field much anymore, deceased organs among potential recipients, and the policies must do these 5 things, okay? Based on sound medical judgment, seek to achieve best use of organs, et cetera, et cetera. Designed to avoid wasting organs is the 5th one. And then it also established performance goals. And these were basically, I think what's interesting here in this middle paragraph, set priority rankings to the extent possible through objective and measurable medical criteria. In other words, when you're going to figure out how to order the people in line, you should have some system to figure out who's sickest, okay, and put them higher in the line. And they also said this in this rule, that we should be distributing organs over as broad a geographic area as feasible under those first 5 criteria: sound medical judgment, avoid wasting organs, et cetera, and in order of decreasing medical urgency. So remember I said that the line isn't really a line. I mean, think about, there is one national list, but where you are in the line at any given moment depends on where the donor is, right? So if you're listed here at HCMC for a kidney transplant and the donor's at Minnesota, you're going to be higher on that list than if you were in Madison because you're closer to the donor. So while, yes, there is one list, the list is dynamic in the sense that the ordering of you on that list depends on where the donor is that's being offered at the specific time. But this was key here, and the key word in this that an epidemiologist struggles with is feasible, right? How do we decide what is feasible? And that is the crux of the problem here. So this is literally where we are today, and I pulled just the key clauses. So we are supposed to be distributing organs over a broad an area as feasible, et cetera, subject to these constraints in number 1 through 5 at the bottom of this page: sound medical judgment, best use of organs, et cetera. So the only reasons in the law to restrict broad geographic sharing is to achieve one of these goals. Okay. And I actually spoke a month ago, a similar talk over at the systems, industrial engineering and systems engineering department across the river here. And maybe this isn't as exciting to epi students, but they love this. So, if you've heard of linear programming or optimization, this is exactly that problem. You have an objective that you're trying to maximize according to a set of constraints. Okay. So if any of you have done linear programming or optimization problems, this is big in the field across the river. In fact, they have a team over there who's actually interested in getting involved in transplant. And we work with a team at MIT in their engineering division as well that helps us with this as well. So I'll come back to that linear optimization problem. Yeah, go ahead.
I just have a question about, so when you get put on a list, is it where your normal care would be, like where they would actually assess whether or not you're eligible for this list? Could you essentially go to a different hospital or a different location and get yourself moved up on a list by being closer to like a larger amount of potential where you're?
Great question. You can list wherever you want. The determination of where you are relative to the donor is based on the hospital that lists you. So even if you live in Blaine, for example, but you listed HCMC, your location is HCMC and the donor's location is the hospital they're in. Okay, but there's nothing in policy that says you can't list wherever you want. And I'm going to come up with an example in just a moment that points that out, right? So
Quick question based on your geography information, when someone dies and they're gonna be a organ donor, about how much time are we talking to get the donor into a living person? Like, how long will the organs be viable? Rough estimate.
The answer is it depends on the organ. Kidneys can go days on ice. Now there are new technologies where they keep the organs pumping out of the body. They put them on these machines that can keep the lungs breathing, keep the heart beating, things like that. Kidneys can go days. Hearts you're talking 8 hours for hearts. Lungs about the same. Livers are kind of in the middle of those two. It depends on the organ. Some of the organs are more susceptible to being outside the body. So back to your question again, very astute. So you can list anywhere. And I mentioned this already. This was the local, what we call the donor service area as the first unit of allocation. Remember, any donor that pops up in any of these areas would be offered in those colored areas first. And these were how policies were designed. And if they couldn't find someone there, then they would go to what was called broader regions. These were administrative regions set up by UNOS. And so what this means in Minnesota, for example, on the left, they would ask in the yellow area first. If they couldn't find anybody that wanted it, then they would broaden their search to the yellow area on the right, which would include Wisconsin programs and programs in Chicago and other areas of Illinois. But notice they still wouldn't call it Des Moines. This still doesn't make a lot of sense. They were sending organs way down southern Illinois rather than to Des Moines. And if you notice Texas, anybody from Texas? Okay, then I can make fun. Texas is a mess. There are 3 organ procurement organizations in Texas, and you can see that the service areas are fairly contiguous. I mean, they're like the blue area jumps around, it skips over counties, it's crazy. And the yellow area, the same way. Yellow handles parts of down by Houston as well as way up into Amarillo, up in the Panhandle. This was, the way that the government set these up was not optimal, in my opinion. And they allowed the organ procurement organizations in those areas that as they were developing to basically get counties because they had relationships with those hospitals. Okay, and Texas is the worst offender of this. But what happens is, I'm gonna come over and just point at it. So this is getting back to your question about where you live, right? Like, so this yellow area here, that organ procurement organization is in Fort Worth. And they handle Fort Worth as well as this whole area up here and basically the outskirts of Houston. And the purple is Houston, and they also handle up here in Dallas. Okay, so this is great. So if a donor pops up in Fort Worth under these systems, they would call Houston before they would call Dallas. They could drive it to Dallas, right? But they might fly it to Houston. It's crazy. And people started to figure this out much too late. We were kind of onto this for a while and complaining about this. If they can't find someone on the right, then they go national. So that's how the system went. Okay, yeah, question.
Are those regions like based off of like population density?
No.
They're just like arbitrary.
They're arbitrary. Yeah, a lot of them abide by state lines, but not all of them. I mean, you can see examples, right? I mean, even Minnesota, we don't get that corner county because that goes to Madison because there is a donor hospital there, but they're closer to Madison, so they have this relation. I don't know. But there's a lot of crazy examples. This blue area goes to Memphis, even though the Nashville OPO handles around them.
Is the OPTN like population based or
No.
also no?
None of it is.
Okay, none of it.
No, there's smarter ways to do this.
Did patients figure this out?
Yes. The patients finally figured this out. Yes, that's a great lead in. So this is an example in liver of what happened under this type of policy. So what we're showing here, liver patients, remember this medical score where you're supposed to rank people by the medical score? Liver has what's called a MELD score, which stands for Model for End-Stage Liver Disease, and higher is sicker, okay? So this is a map by those donor service areas. So the purplish zones, that means people are sicker at the time they get their liver transplant than the green zones, okay? So this is one way, there are probably other ways, but to measure equity or to measure the disparity in access, okay? And this is what resulted from a policy that used those service areas first. And we first were looking at this and trying to figure this out. But there was a famous example that really got people talking about this. Does anybody know who got a liver transplant that was?
Steve Jobs.
Steve Jobs, yeah, that's right, yeah, Steve, yeah, Apple CEO. Of course, he lived in Silicon Valley here in the red. And does anybody know where he got his liver transplant? Close. Memphis. So he went here, which is one of the green zones. So people started to say, well, Steve Jobs is rich. He probably bought his way to the top of the line. That wasn't true, but it started a national conversation because it was high profile. And people started asking, why did Steve Jobs fly to Memphis to get his transplant? And because Memphis actually had a really aggressive surgeon at the time. He was taking offers that other surgeons wouldn't take. He was getting transplanted people very quickly. Steve Jobs obviously has the resources to get there quickly. They call, he's got private jets and whatnot. But it started this national discussion about fairness, right? And we shouldn't be flying people to organs. We should fly organs to people if feasible. So we get back to the word feasible. But we were trying to think of smarter ways to do this. And then you said, did patients figure this out? Yes, patients started to figure this out. And there were a few high-profile lawsuits that came to be. This is an example. So this, I'll underline this bottom paragraph. They sued the government to, within 6 months, create a new liver policy that's not based on arbitrary donation service area lines, but rather as a zone-based distribution policy. Okay, meaning, you know, like zone A, zone B, we call these concentric circles, like just start with circles around the donor and get bigger and bigger as you go out. That's one way you could do it. So let me back up here. What really happened in this case, it's worth pointing out. So there was a patient in New York City here. And you can see that's like purple zone, and the northern New Jersey area was a bit better, okay? There's a hospital in Manhattan that is on the Hudson River, okay? And there's a hospital across the river that's in the New Jersey area, DSA, right? And there was a woman waiting for a transplant at that hospital, and she was trying to figure out how the system works. She was asking questions, and she said, wait a minute. So if a donor pops up across the river at that hospital, I can see out my window. They're gonna call Philadelphia before they call me in New York City. They could literally drive it to me in 10 minutes. And the answer was yes. And she sued and she won. Okay. So I think that having patients start to figure out that this doesn't make a lot of sense was a good thing. It shocks me that it took so many years to figure this out, right? But you know, sometimes policies are hard to move ahead. Back to this linear optimization problem. So we work with this team. They were at Johns Hopkins at the time. Summer Gentry is a mathematician. At the time, she was a mathematician at the Naval Academy. They have since moved up. They have moved their whole research team up to New York University, NYU in Manhattan. So she works with us. She's on our team as well. And she published this paper, Gerrymandering for Justice. And this was in an operations research journal. And she basically, remember that linear optimization problem? We're trying to optimize donor supply demand equivalency subject to those constraints. She drew this out mathematically. I won't get into the equations, but that was the optimization. And essentially what that's saying is she's trying to optimize the donor supply imbalance, the supply demand imbalance in the areas that we're trying to optimize against, subject to those constraints in the final rule. And these, I won't read them down. The engineering people across the street were more interested in this slide. I don't even know what a lot of these equations mean, but this was the linear optimization program. And she could specify how many districts. What she was doing was saying, are there just smarter ways to group those districts together? She wasn't saying get rid of the districts at all. She was just saying, could we do it smarter? And then she let the computer figure out the best grouping of donor service areas to make this more fair. And so she came up with a 4-district solution and an 8-district solution. And then showed, so the dots on the left that are really high are the deviation, the standard deviation median melted transplant. So that's like the variance across the areas of the country in that medical acuity score. So higher is more inequity, lower is better. So all of the maps that she built, you can see most of them in all of those other dots to the right were some variation of 4, 6, 8, 10 districts. She looked at lots of different things, ways to do this. And basically the take home was anything's better than what we're doing, right? Anything is better. So then this continued to spark debate about the best way to do this. And now maybe you've heard this term continuous distribution framework. And I just harken back to the 1998 comment from Health and Human Services. In bold there, assure that organs are allocated on the basis of medical need and availability of organs will not be impeded by arbitrary geographical lines. And remember that the lawsuit said we could create circles, concentric circles. In my opinion, those are still, they're still lines, right? Somebody could be just inside the circle, whereas there's somebody really sick outside the circle, they wouldn't get it. So we published a paper just a few years ago, 2018, that you could do this without any lines. We called it just distribution without geographic boundaries, and this is a possible way to do this. And this took traction. They actually spun up a national committee to debate this, and they chose to go with this. But the simple idea is this: you have that medical priority score, which the law says you have to have. And then I grabbed, this is my language from the paper, you have a geographic feasibility score. You have to define mathematically what's feasible. And then you just basically add those up, and then you can sort the list by that. It's pretty simple, right? But people are having a hard time getting their head around it. This medical priority score is how we would allocate, I call it how we would allocate if there's no shipping problem. If you could magically beam an organ anywhere in the country, like Star Trek style, then how would we order people? That's the medical acuity score. But we can't do that. So then we have, these already exist. We already have scores in most of the organs that do this. So then we come up with this geographic feasibility. We have to have some penalty on geography, right? It's not feasible always to ship them as far to get to the sickest person. So we have to come up with that score. You add those up and you get your allocation score. That's the sort order of the list. And this is the picture that I think sold our community. Sometimes you have to draw funny pictures, right? This picture was from the paper that I published. And I was basically just trying to describe to the community how this works. And the idea is essentially, you have a donor that's located at some hospital, we just call that here, and you have a feasibility score. The axis is arbitrary, just like higher score is better, right? And then the slope, I called it, imagine that person standing on the peak of a mountain. And the slope of this line is like down the side of that mountain. So the farther away you are from the donor, and 6,000 miles is about the maximum distance in the US, like Hawaii to Puerto Rico. Okay, there is a transplant program in Puerto Rico. They're part of our system. So eventually, essentially what you're saying is you're going to penalize distance. And then for each candidate that's on the list, remember there are 90,000 kidney patients. So there's 90,000 people on this hill, and they're standing however far away they are from that donor. And then they have a flag, and the flag is their medical acuity score. Okay. This is how I convince the policymakers that they should think about this. So this person, because their flag stands taller than this person, even though that person is closer to the donor, we're going to offer it to this person first because they've got a taller flag, and the penalty for distance isn't so great that that flag becomes lower than the one before it. Okay, so we basically said that's the general idea. In practice, it's obviously a lot more complex than just that, but that's the concept, right? It's pretty simple. You're penalizing how far away people are based on some score, and then you have how sick they are based on some score. You add those up, that's your score. So the committee voted to do this. They're in the midst of transitioning all the policies to this. Lung was the first to go, and Lung actually expanded on my idea a bit. And they have this urgency score, okay, but then they also factored in the survival of the patient if they get the transplant. So like, is this a futile transplant? And then they had some other point boosters that they wanted to incorporate for other things to basically create equity better. As I mentioned, the height match is important in lungs, so they wanted to factor that in. Prior living donors, these are kind of social constructs here. Our policies will promote people that have been prior living donors. So if you need a transplant and you yourself have given a kidney to somebody, the policy will boost you. You get rewarded for that if you then need a transplant. And our law allows for us to favor children. So all else equal, if there's a child that needs a transplant and an adult that needs a transplant, it will go to the child. Okay, so that's what this is in here for. And then these were the hill. the slope of the hill. They divided it into travel efficiency and proximity efficiency. They came up with scores to show each of those. They put this out for policy. They're gonna establish continuous distribution for lungs. They had all of those components that I showed you on that slide, and they picked weightings, like how important is each one of those in the weighting system? This gets back to the optimization problem. MIT helped figure out what the correct weights would be. Of course, they favored nice round numbers. They're not like 4.8%. But then they have all of these formulas. I won't belabor them, but how do we talk about efficient management? Those are the travel efficiency points. These are in the policy. So the NM is nautical miles from the recipient to the donor. So these are how they actually conceptualize the functions, the hill, the shape of the hill. And then the proximity efficiency points as well. They divided those two things up. So again, based on nautical miles. And this is how it all works. They had components that fit into the efficiency in the dark blue, and then the green, they were looking at cost, like how much does it cost to fly things? And when you look at that cost scale, this is the actual scale they put in the policy. And you can see that if you zoom in on that left part, that's what it looks like. And basically this is saying that within probably 50-ish miles, you're probably driving the organ. And then there's a transition zone where you might drive it, you might fly it. And then once you're past 100 miles, the OPO said, we're flying those organs. So the penalty slope, that's how this function came to be, right? We want to not penalize too far when you're driving, but then there's a steep penalty where you transition to flying. But once you're in the air, going another 50 miles doesn't really matter. So the slope of this flattens out again, right? That's how it was built. This was the proximity efficiency weights. They chose a curve on that one. And then these are the formulas they use for the acuity piece. And then when you add it all up, this is how they calculate the continuous allocation score. So basically they go through some examples in the policy of how you do this. This person ends up with a score at the bottom of 52.5182, and then you just sort everybody on that score. And that's how you offer the organs. It's pretty neat. So this is a graphic of what happened to the transport distance on the lungs once that policy went into effect. The left line that says continuous distribution was the first time that they implemented this in March of 2023. So remember, the law was harping on this back in the 90s. It took us till 2023 to get it done. So, but you can see that this is the median travel distance in nautical miles. It was below 200. Once we started broader sharing of lungs, it jumped by about doubled up over 400 nautical miles. So to this day, there are programs and insurance companies crying foul. This costs too much money, right? But the neat thing about this is you can have that debate now. You say, how much is it worth the money to save people's lives? And when you look at what happened to the transplants per death, so the left line is the initial introduction of the policy. And the way I interpret that is there were a lot of people that were sick that weren't getting the offers they needed. There was a bolus of them. They got all transplanted quickly. They started to come back down. We made us change to the blood type points. That's that ABO score modification. And again, there was this bolus of patients that got transplanted quickly. But this has generally, since continuous distribution went into effect, we're getting more transplants done. Transplant rates went up. Deaths on the wait list went down. This is the wait list mortality rate when this policy went into effect. So fewer people are dying. Is nice. And I just like to close by saying this all starts with a donor. So I serve on I just rolled off, but the board of Donate Life America. So now they have a national registry. You can either do this on your driver's license, or you can go to registerme.org. And we work with Apple. Apple, of course, has been very supportive of transplant because Steve Jobs got a transplant, right? So they actually came and said, we would like to build into your iPhone the ability to register to be an organ donor. So in the health app, you can actually do this, and they put your registration right into the national registry. So that's a cool thing. And hopefully that was interesting. I'm thoughtful about how we deal with epidemiology and transplantation, the interesting problems we're trying to solve. So thanks for having me. Took too much time.
No, not at all. That was so interesting. I was on the edge of my seat. I was actually just thinking about how there are things that you said about kidney transplantation 20 years ago that I still think about. I have no idea how this works. Thank you so much. I have a special present for you. For the seminar. If you're already at the top of the hour, so I know some people have to leave. I don't think anyone's coming into the room right away, right?
Not right away, but Jill will be speaking up.
At 11:15.
Yeah.
So if anyone wants to stick around and ask a few questions, you can. I think we gotta leave the room around 11:30. Well, thank you so much, John.
Thanks for having me.
Fantastic. Oh, so many questions. I knew it.